So what's new? Data from 2016. Obviously, I'm not going to talk about all of it, but I'm just going to select various bits and pieces. So the topics I'm going to deal with are four. Firstly, the evolution registry. Secondly, the European guidelines, briefly. Thirdly, the left atrial appendage in intracranial hemorrhage paper. And fourthly, the amulet registry. So firstly, of those, the evolution registry. To start with, this wins the award for the worst acronym of 2016. It's extremely convoluted and it doesn't even make a word. So, but leaving that aside, it's been quite good. It's a 1,000-patient registry, all comers, conducted in many different countries, looking at outcomes with the Watchman device. And you can see from this slide, about 1,000 patients were recruited into the study. And if you look at the successful and unsuccessful implants, only 15 were unsuccessful. So that gives a rate of 98.5% implantation success. And the analysis included transesophageal echo at 30 days or before in 80% of patients. It's worth pointing out that this is very different to what was done in PROTECT AF because the contraindications for anticoagulation are notable. That 70% of patients had significant contraindications. Procedural success compares very favorably with how it was in the previous studies. Gradual increase throughout, as you can see, getting up to 98.8% there. And the serious adverse events going down, study by study, still higher than you'd like for a preventative therapy, but 2.7% in this study. Safety endpoints out to 3 months. There were bleeding events in 4% of patients, and that, I think, reflects the high-risk cohort that were recruited. Device thrombus in 3%. Again, obviously more than the manufacturers and the clinicians would like. Mortality, I was a bit surprised that 20 patients had died by 3 months in this study, and details aren't exactly clear, but certainly don't appear at this stage to be device or procedure related, except in a very small proportion. And it's good to see that device embolization and procedural stroke and subsequent stroke are very low. So the conclusion, a little bit verbose, but nonetheless makes the point. High success rate and improvement in implantation techniques over time. So a steady increase in quality. So then the European guidelines on management of AF. There is a debate on this later, so I will be relatively brief, but I don't make a habit of reading the guidelines because they're usually very long and very boring. And they're usually very conservative and out of date by the time they get published. That's just a general comment about guidelines rather than these ones. But the 70-page document devotes one paragraph to left atrial appendage occlusion. And in that paragraph, there's some quite surprising statements. It says, left atrial appendage occlusion was non-inferior to warfarin with moderate stroke risk with a possibility of lower bleeding rates in the patients who continued follow-up. That's extremely lukewarm, considering that one group is on warfarin and another group is not, and the evidence from PROTECT AF is extremely strongly in favor of the reduction of bleeding events. So I was a bit surprised by that one. Then a rather woolly, sweeping generalization that most patients who historically would be considered unsuitable for oral anticoagulant therapies seem to do relatively well. That's a great sentence. I'd like to get that one past a sort of a commissioning board. They seem to do relatively well on contemporary managed oral anticoagulant. And then this one was the most interesting, perhaps. The implantation procedure can cause serious complications. Of course, that's true. High event rates reported in analyses from insurance databases and systematic reviews, possibly identifying a certain degree of reporting bias. That's a very interesting statement. I'm not entirely sure exactly what they're getting at there, but if it's reporting bias we're looking for, then the disclosures of the authors of this particular guideline can be viewed on the ESC website for those who would like to see them. So, in summary, one recommendation that was related to percutaneous left atrial appendage occlusion, the other three on here are surgical, and it's a level of evidence of 2B with a level of B. The next paper is, I think, the one that's been, in a sense, most overlooked and is going to be most influential out of this year's papers. This is an extremely clever propensity analysis of patients undergoing left atrial appendage occlusion for intracranial hemorrhage compared with a data set from Denmark of patients who've had intracranial hemorrhage, are managed medically, and have already survived more than half a year. It's a typically understated Scandinavian effort. Many of us would have been shouting a bit more about this if we'd done it ourselves, because it's extremely good work. So 170 patients taken who had left atrial appendage occlusion following intracranial hemorrhage, and propensity matched against 800 coming from the kind of database that the Scandinavians do best, which is a national registry of intracranial hemorrhage. You can see 800 patients, from whom 150 propensity matched were derived. In that group, a 98% implantation success rate, consistent with what we've just heard. And worth noting that the proportion in this second paragraph here on warfarin, novel oral anticoagulants, etc., etc. So it's quite clear in the left-hand group, for example, that people are very unsure what to do with these patients. Can some of them go back on anticoagulation? Must they mostly stay off it, etc.? Anyway, it's resulted in a graph that you don't often see in medicine. It's one that doesn't really need a p-value appended. A combined endpoint of ischemic stroke, major bleeding, and mortality strongly favoring left atrial appendage occlusion. And when you look at this in slightly greater detail, just on the mortality, it's difficult not to be impressed by the difference between the standard care, 23 deaths, and left atrial appendage, only 2. Similarly, when you look at the relative risk reduction, in all groups, ischemic stroke, major bleeding, hemorrhage, mortality, very major relative risk reductions. And the reason I say I think this will be really influential is, apart from the fact that it's a really good paper, a lot of the commissioning groups, certainly in the UK and maybe in other parts of Europe, are saying, yes, but you want to put these devices in people who are anticoagulant intolerant, and actually there isn't any data on those, so we're not paying for this. Well, there is some data, and now there's more data, and I think it's going to be very helpful, and I look forward to seeing the full paper published. I'm interested, actually, because I've got to keep you awake, and I've got to ask questions. Wim says I must ask questions. So can I ask this question? Will this work with the voting system? I'd like to ask if you were aware of this data, because Jens Erik doesn't like to blow his own trumpet, so I've had to blow it for him. So it's a 1 for yes, and it's a 2 for no. Can we have a go at that? I don't really know what happens now. I wait, okay. Okay, I think they've finished. How's it going? I'm going to be tempted to make it a show of hands. Okay, too difficult. Right, so who was aware of that data? Okay, so some of you, not that many, but more of you are aware of it now. Okay, I'm going to move on. So the Amulet study is the last study I'm going to talk about. I was privileged to be given the chance to present this at TCT last year. I was going to ask if you're aware of this, but I'm going to do that by a show of hands as well, whilst they work out how to do the thing. Who was aware of all this data? Yeah, again, well, some, not all. Okay, well, you're going to find out a bit more about it now. So the design of this was broadly similar to Evolution. 1,000 patients were involved in the study, and of those, in only 13 was a device not implanted, so that's a very high implantation success rate. The patient population was, again, a typical European patient population now, where the majority were anticoagulant intolerant with high CHA2DS2-VASc or HAS-BLED scores. In fact, when you look at it more closely than that, the indication was either that there were contraindications in 85% or that patients had had a recurrent stroke despite oral anticoagulation, and only 5% fitted in the other category, which was largely patient preference. So the implantation procedure itself, 10% done under intracardiac echo, and that was then presented at a subsequent meeting, that group, with very good results. And interestingly, despite all the agonizing about sizing, the first device taken was the device implanted in 19 out of 20 implants. The implantation success was 98.8%. Again, very good results, probably better than perhaps most implanters might have expected. Then major adverse events, 3 procedure-related deaths, unfortunately, 3 strokes, some pericardial effusions, amazingly only 1 embolization out of 1,000 cases, and the majority of the major adverse events were related to bleeding. It's worth noting that in contrast to what has happened with the Watchman device, because it was originally required that patients would have anticoagulation, and indeed in America, that's, I think, the physician's expectation is that warfarin will be needed. But in this registry here, over 80% were managed on antiplatelet agents alone. The closure rate seen on TEE, and this was from about 350 cases so far at that stage, increasing all the time, of course, showing an extremely high closure rate, probably at least partially related to the design of the device with the lid, 99%. And a comparison to other studies shows very good, very consistent results. So the conclusions from this registry were that the high technical success rate was seen, that the implantation procedure itself was associated with low rates of complications, that the closure rates were extremely good, and antiplatelet therapy appears at this stage to be a reasonable strategy post-implantation. Of course, further data will come over time. So, in conclusion, 2016 has yielded, in my view, 4 key publications. 1 slightly disappointing guideline document, 2 large registries with over 2,000 new implants and a 98 to 99% success rate, and ever-reducing complication rates. 1, I hope, very influential paper on left atrial appendage occlusion in intracranial hemorrhage, and overall, everything's looking pretty rosy. There are ever-improving outcomes with left atrial appendage occlusion. Thank you very much.